sustainability is really a choice. The way that HealthBridge was set up, it was designed to be governed by the customers, the stakeholders in our community. They funded us. We started without grant funds. The idea from the very beginning was to operate as a business, to have more revenue than expenses. The discipline to follow through on that, to evaluate projects and understand how they'll be paid for based on who gets value from them, is just part of our DNA. It's how we started and how we continue to operate. So sustainability is really just defined in terms of the services that we go out to deliver to our customers, and they drive that. They have a lot of input into that process, and of course control the prices. So the primary services that we offered in our early years started as really a portal, a community portal that would let all of our hospital customers and others make their clinical content from their health systems available to others, usually physician users, and then many other users in their offices outside of their campus. Way back when we started in '97, that was not something that was easily done. And because it's so convenient for the people in physician offices and really many others to go to one place and to be able to get access to the clinical content from virtually every hospital in town, we see the use of that service continuing to be out there and provide value, and utilization is going up. The other big piece of what we do we call clinical messaging, but what it really is the standardized delivery of all manner of clinical results, everything from the laboratory, everything that's dictated and transcribed in the hospital, everything out of the radiology system, the actual printed reports, not the images, though they can get to those through the portal, as well as certain ADT transactions, all come from the hospitals, the national labs, local radiology centers, to us in a standardized way, and they're delivered to virtually every physician in town based on how the physician wants to receive it. From mail and fax to the EMR Lite that's deployed that physicians can use for free across the community, right up to getting it to their electronic health record in their office and working with their vendor to get it right into their workflow automatically. Those were our two biggest services for the early years, up until the ARA legislation, and we're now a regional extension center. So we've been thinking a lot about meaningful use and really how we marry the health information exchange and the regional extension center together. Critical aspect of how we'll deploy the REC is we will work with electronic health record vendors that agree to enhanced interoperability. So those are the big services. There are many other types of services we provide for various customers, but those certainly get the vast majority of what we work on. The major challenges are many, and a lot of it is ramping up the organization to deliver the new services that we've been talking about. As there's more and more interest in health information exchange, as we expand the scope of what health information exchange does, as we work with the regional extension center, the big deal is trying to stay on top of it, trying to make sure that we're delivering the service levels that our customers have come to expect. A big part of how we're managing that is we're developing additional tools to be able to monitor and understand the delivery that's happening within the health information exchange. So think of it as several levels of management dashboards that we think other RECs and health information exchanges might be interested in as well. Well, it helps us keep our finger on the pulse of what we're deploying. We're bringing in a new, more sophisticated project management system so that we can stay on top of the various grants and other contracts that are out there for us to do. Some of the other barriers really just have to do with the weight of our success. We're moving lots of data. There are lots of different people that want to jump in and begin to to utilize data from the Health Information Exchange. So we have to make sure that our privacy and security, our contracting, our communications with our customers who are sending the data through us, all of that needs to be aligned in a way that makes sure that we maintain the trust that is what Health Information Exchanges need to operate. I'm a little concerned, I wouldn't put it a major problem yet, but I'm a little concerned that many of the EHR vendors are so overwhelmed that it could be more difficult than we would have expected to work with them and pull them in and get them to do what we think they need to do for the Regional Extension Center and other work. Well, meaningful use is a lot of it is very much in the sweet spot of Health Information Exchange. We view it as a big part of our role to enable the coordination of care regardless of where that patient presents across the community. So all of the aspects of meaningful use that are about the movement of data, laboratory results, and so forth is something that we've been doing for a long time. There are fascinating new components of meaningful use that dovetail to other projects that we've been working on. Most significantly, the idea of being able to extract the quality improvement data, the data that you need to really understand and monitor the quality at the physician office level. We'd love to make that a byproduct of the care process. We've been working with the Health Improvement Collaborative, our sister organization in Cincinnati, as part of a Robert Wood Johnson Aligning Forces for Quality grant to rather than use clinical data to measure quality, to go directly to rather than use the claims data to measure quality, go directly to the clinical data to extract that and move it to a registry so you can get to the quality metrics. The other fascinating part of meaningful use that some have said would be very hard, that we think would be very straightforward for us to continue to do, is all of the aspects of the public health reporting. It's easy for us because we capture the data as it comes through the single standard pipe that the clinical data is delivered through. It's straightforward once the results are marked to pull them out and move them through the public health reportable disease process. So we just have to work with the labs to do that, as opposed to going to each EMR and figuring out how they can identify and submit results. So the meaningful use is there are many other aspects of it that the HIE will be right in the middle of, from e-prescribing to the continuity of care documents we'll be able to move. So it's a big part of our future. We're very excited about our ability to operate with as the REC and with providers in our community to make this happen. Engagement of consumers. It turns out that in our assessment of engagement of consumers, it's clearly a pivotal part of really moving healthcare. Patient compliance, patient understanding of what their condition is, enhanced communication between a patient and many other healthcare stakeholders, including their physician. We see a role of the HIE being right in the middle of that. As we are able to feed virtually every different electronic health record that has presented in our community, we anticipate being able to do the same thing with the personal health records that patients may choose. So we want to be able to maintain the idea of consumer choice, picking a personal health record, but to add value to that personal health record by not just putting their data into it, but by letting their personal health record connect back to the healthcare community, to their physician, to manage their preferences in terms of who can see what and so forth. So we really see a significant growth opportunity in being able to engage patients in this way. What's the future of health information exchanges? How are these things going to mature and work? There's not a clear picture of that. There are many people trying many different approaches. The way that we've thought through it, we want to continue to focus on the medical service area. We love the fact that our stakeholders are so engaged and progressively more and more engaged as we add new stakeholders and add new services for them, that we see several iterations of additional services that will add value for all of our stakeholders. The ability to streamline healthcare, to offer hospitals, for example, an opportunity to cut some reporting functions and other things that are very expensive for them to do. I think those will be the province of health information exchange. The using a systems approach, looking at the medical service area, the community as a system, and pulling it together in a way that can directly address the fragmentation of healthcare, which, according to the Institute of Medicine, is the major determinant of value. As fragmentation goes up, value goes down. What we're really doing in our community is moving toward the integrator hub of the IHI model that will help us go beyond the current focus, which is primarily on the care delivery, the quality, the access, and to add the dimensions of population health and cost. As we do that, we anticipate being able to energize the participation of the health plans and the large employers in our community as stakeholders, sitting around the table and developing the new processes that will lead to a fundamentally more efficient health system. In a nutshell, we're moving from a health system organized around where you happen to get the care to a health system organized around you, around the patient. So that's where we see it going.